Yes.
Recorded, so I'll sit here and be the audience.
Yes. So today we have Robert Dyer with the Cozad Community Health System, and he's going to talk all things community health system with us. So welcome.
All right. Well, thank you for having me, Lori. I appreciate it. We'll just go ahead and get started here. So am I standing in the way of that if I'm?
No, you're fine.
Okay. All right. So I just named this hospital happenings because we just had some general communication about what's going on at the hospital. And one thing we'll talk about is if you've driven by the hospital recently, you'll notice that we've had a pretty good addition. We're licensed to be a 20-bed facility. When you look at our prior rooms, we had shared rooms with patients sharing a restroom. They had to go down the hall to take a shower. A curtain dividing those rooms. You know, HIPAA security wasn't always good because you could hear, you know, what was being said on one side of the curtain to the other side. And certainly we knew that it was time to consider making some upgrades there, not only for infection control, but for, you know, being provider of choice in our area, and just getting to the standard of care with good, high quality functioning private rooms. And so we've certainly got to that point. I'll show you some pictures here in a moment. We also were able to get some additional grant money too. So the cost of those private inpatient rooms was funded by COVID dollars because Dawson County was a area of high utilization with COVID early on in the pandemic. And so we were able to fund that inpatient addition with that COVID money, with CARES Act dollars. Our pharmacy, we were able to work with our local community and get a red light grant. And so previously our pharmacy was essentially kind of shoved in a little bit of a large closet. But what we did was we took the old nurses station area, the old ICU beds, the old nursery area, and then the pharmacy area. And we were able to kind of redo that area. And now we've got a really up-to-date pharmacy. And we'll talk about that in a minute in terms of the services we'll be able to provide through there. We did retain 2 of our old semi-private rooms on the south side of the main hallway across from where the pharmacy's at. And those rooms are going to be utilized as infusion rooms now. So if you're needing blood transfusions, IV antibiotics, monoclonal antibodies, will be able to be in those rooms. They've received a significant facelift. You know, the footprint is the same, but new casework, you know, wall protection, new flooring, all that, the new tile in the bathrooms, they've really been brushed up. The nutrition center you'll see, and that's just went over really well. And then the new nurses station. So we'll kind of go take a look at some of the photos here. So these are our new standard rooms. So of the new 14 rooms, 12 of them look like this, or the mirror image of this. They are really nice size, and quite honestly, the pictures just don't do them justice. And if you ever want to come up to the hospital and take a tour, I can take you over there and show you what they're like. But when we were looking at making these rooms and planning them out, how are we going to lay these rooms out to have them function best for the patient and for the staff, we went and toured some other facilities, and one of those facilities we toured was North Platte. The rooms are laid out a little bit different, but I can remember being there just thinking, these rooms are huge. I just thought how large they were. Our rooms are only about 6 inches shorter each direction from theirs. And there was actually a friend of mine that's a therapist in the North Platte area, and he was a former student of ours, and he stopped by last week, and I said, hey, you got to check out, you know, remember our old setup? You got to check out our new setup. So we went and looked at the new rooms, and he's like, wow, I really like these. And I told him that we went and visited North Platte, and he said, you know, I like the layout of these a little bit better. But what we did was we kind of came up with some plans with architect, and then in the large garage out at Meadowlark Point, we taped out on the floor the dimensions of the rooms. We took a hospital bed out there, took the exact furniture that we've got in the rooms out there. We utilized walkers, wheelchairs, crutches, canes. We even had a toilet sitting out there, and we simulated what it would be like to take care of the patient. And then based on that, we made just a couple tweaks. Okay, let's shift this 6 inches here, and let's shift this, 8 inches there. And then we ended up with what we've got. But everybody was involved with planning this, our maintenance staff, our environmental services team, whether it's the products that we were using for infection control, the ease of cleanability, even the sinks, so we can get under them easier with a mop, just grab bars in the shower. Our OTPT staff was really looking at that, and then adjustable shower heads with a flexible shower wand. Just every single thing was really looked at from all aspects of our healthcare system. And if none of you have been up there before, I encourage you to come up and take a tour, because it's really nice. 2 of our 14 rooms are rooms that are larger. They're about 4 foot larger in each direction, and they're made specially for bariatric patients. So, as our society continues to get larger, we need to be able to care for individuals that are heavier and in that morbidly obese classification. We do have a lift system in those 2 rooms. So there's a mechanical track and lift system in the ceiling. And that way we're able to care for patients and decrease the risk of injury to our staff. And during the planning, I thought, well, do we really need 2 of those rooms? Because if I'm thinking throughout the time in our healthcare system when we've had to order in special beds for individuals that would need that service, it wasn't happening a lot, maybe once every 2 years or once every 3 years. So I thought, do we really need 2 of those rooms? Well, the day we moved in, we had an individual in our community who needed that due to an injury where they're no longer able to walk. And then the next day had an individual that had been confined to a wheelchair their entire life and had been lifted with a lift their whole life too. And so when you look at the utilization of those rooms, we use them all the time. So, there's a lot of residents at the nursing home that haven't walked for years, and they're being handled with a lift. And so that service has been very instrumental and just a big plus for our community. So this is kind of the hallway looking north towards the south, and this is looking back towards the main lobby area. This is our nutrition area, so patients and their families can come get snacks. We've got some drinks, and we've just been getting a lot of really positive feedback about that. The Cozad Hospital Foundation did help support the nutrition center area for funding there. Our nurses station is certainly up to date and a great workspace. This is just kind of a video of if you were to come into the hospital lobby, you were going to go through the double doors, and then this used to be our old inpatient area here. It would go down and then through where you see the wall on the end. But these rooms to the right would be our infusion rooms. And then to the left, you can't see that because that's all a secure area, but that's where the new pharmacy and med room area is. There's a little lobby right around the corner. And then here's the nurse's station here. Down this hallway then goes to, towards our surgery area. And then come down here and you can go right or left. And then these are all our new patient rooms there.
How many of the new rooms are there?
14. Yeah. And the grass detail that was along the nurse's station, we weren't exactly the most fond of that, and that's going to change. So,
When you say infusion rooms, Robert, do you do dialysis or is that a special?
no, that's another specialized service that we don't offer here. Kearney and North Platte are the nearest sites for that.
And then the 14 rooms, maybe you said that and I missed it. Are they all single rooms?
Yes, they're all private rooms. Yeah. So this is an example of the lift system in our bariatric room. And so we've got Taylor and Emily using Larissa as a model patient. The track system goes into the bathroom, so you can take someone in and place them over the toilet if needed.
That's amazing.
Yeah, it's just really, really nice. And just look at the size of that, you know, that bathroom is, again, the picture just doesn't do it justice. But everything in there is ready for additional weight. The grab bars along the side of the toilet, all of that is set up to be able to handle that.
So we have all the new rooms that are private. Are the other rooms still set up for 2 patients in the room, or?
So the other rooms then, most of those got torn off because there was a little peninsula of rooms that went out and back. And so we had rooms on each side of that peninsula. Those got removed and then we built down across that area. So there were 3 remaining rooms that weren't removed as part of the peninsula that would have accounted for 6 beds. Part of that area is now a therapy room. Another area of that, it was where the nutrition center went. And then right next to that would be the director of nursing's office there too. Then the other 2 remaining rooms are the ones that we repurposed for the infusion rooms. So technically what we've done is we retained the head walls where you have all your hookups for your oxygen and all that on both sides. So if we did have a pandemic where we spiked above our 14 beds, then we still have some other rooms in the hospital down by the surgery wing that we would overflow into. But if we needed the last 4 of those 20, we could go back to utilizing those infusion rooms, just bring beds in there and recliners and set them up that way. So we maintain our bed count that way. But that's a great question. Any other questions about the inpatient wing or?
I haven't been in there for a while, but which is a good thing because I've had phlebotomy.
Oh, yeah.
So I'm familiar with, I was.
Yeah.
But I won't recognize anything.
You won't recognize anything. It looks so incredibly different, yes. So one thing that, when I became the administrator a little over a year ago, I wanted to improve care accessibility. I know that, you know, oftentimes we're fielding concerns from patients in our community that they love their individual doctor, but they just can't get in to see them in what they feel is a timely manner. They're being told that it's a wait to get in, or, you know, especially for those annual visits, you know, getting those pushed several months back. We put a considerable dent in that, but we still have room to gain. And so we're working on some additional strategies to improve that here. But I wanted our community members to be able to come outside of 8 o'clock to 5 o'clock. So Monday, we do start at 8 in the morning, but we go till 6 in the evening. Tuesday through Thursday, we start at 7 to 6 at the clinic, and then Friday, 7 to 5, and then Saturday is 9 o'clock till noon. So we really opened up the availability, and that's helped a lot of individuals that need to get in to be seen before work or after work, so they're not missing work, and that's been a big plus for us. And so as part of that, what we did is we've got 2 new providers, and so Tim in the upper left, he's a PA that joined us back in October. He covers just the emergency room and just the hospital and serves as a hospitalist. So right now, if, say, Dr. Witovic were to admit somebody into the hospital, Dr. Witovic is still going to be rounding on you regularly. He's going to be checking you, but any other little concern that pops up in the middle of the day, if nursing says, hey, Mrs. Smith has, a little bit of increased pain right now, can she, take a Tylenol? That would take a phone call to Dr. Witovic. Dr. Witovic would, have to communicate back, get the order put in, all those things. Well, now Tim can handle that. So then Dr. Witovic can focus on his clinic day. And then also then our physicians aren't carving out a full day at the medical clinic for being on call, taking the acute walk-ins at the medical clinic and covering ER, because they may go over to ER and they could be over there 3 or 4 hours. Well, then all the people they had scheduled for the acute walk-ins that day, then are getting pushed back to later in the day. I don't really like that. So Tim has been with us since October. Jay in the upper right, Jay Meyer, he will be joining us. July 10th is his first day. So that will cover nearly 2/3 of the overall days of the year. We're looking to recruit and add a 3rd person to that model. And then all of our traditional providers that have been trying to be 2 places at the same time, they're going to be able to focus on clinic medicine. And that's going to open up more availability, so those wait times are going to be, shorter and shorter. As part of that strategy, Amanda Smith joined us back in August, and she is the one right now who's taking all those acute walk-in patients. So if you have a child with a runny nose, or you're not feeling well yourself, you're running a fever, you can call and get in and see her. If she's stacked up and full, and there's a lot of days that she is, then one of our other providers will accept you and see you. So
what is the APRN?
that stands for Advanced Practice Registered Nurse. So that's a nurse practitioner. And then recently we added Micah Chrissinger, who's a Cozad graduate, to our physical therapy staff as well. And that's been very beneficial. So when I moved up to the role of administrator, we tried to see if we could go without backfilling my position, but we realized we couldn't, and we needed the extra help. And Mike has certainly stepped in and brings a considerable amount of experience and expertise to our staff. So he's been very efficient. Then at the specialty clinic, we're bringing back urology services. We had lost urology services when Dr. Howe decided to slow down and transition to retirement. Dr. Brown will be starting in about 4 to 5 weeks, and he comes out of North Platte. Dr. McCaig is a pain specialist, and him and his PA will do pain management, and then also we'll do pain management procedures here at our facility. And they've been coming for probably 2 or 3 months now, and that's worked out as well. Diabetic education. This is our new diabetic education team. We had our former dietitian decide to spend more time with her family. And so Jill Nelson is one of our diabetic educators, and then also Kate Dynas. Jill's primary duties have been wound care, and then Kate's primary duties have been cardiac rehab. But then they're also partnering with Alex Kinney from Frontier Family Pharmacy here in town. Alex helps with the education on the medication portion of the diabetic education program. And then Jill and Kate talk about the other aspects of the diabetic education program. Yesterday, they were at the grocery store and had a booth there talking about diabetic education and proper food choices. The Nebraska Beef Council is partnering with us in the next week or two at the Wellness Center, and they will be coming and doing like some healthy cooking classes for diabetics, and so our staff will be up there for that. So feel free to go to that. They'll have food there. And then just highlight the wound care clinic. So like I mentioned before, Jill's dual certified, she's board certified in wound care and then also in diabetic wound care. And then Kimberly Farr is also certified in wound care. Our wound care program has been very successful, and it's just served a huge need in our community and the surrounding community. And we're really proud of that program. It just continues to grow. One service that we've been providing for probably the last 3 years that a lot of people may not fully understand is what we call biologics or biologic tissue substitutes. So essentially it's like lab grown tissue or skin grafts, sort of, to help wounds that are stalled or not wanting to heal well, to help them close more rapidly. And that's been very successful for a lot of individuals. So great service. At the medical clinic, Joe Devin, one of our nurse practitioners, does bioidentical hormone replacement therapy. The brand name for that is BioT. And essentially what he would do is he would take a blood sample, run a hormone profile on the individual, and see if there's some things that we need to do to make people feel better. This is a cash pay service, but most people would benefit then from some, as a lot of his clientele are women, I would say between 30 to 50 or so, I'm guessing. Joe would be a better person to ask with that. But, you know, as their body's changing, that he does some hormone pelleting. And so you get some pellets injected and into your backside, and then people just report having more energy, feeling better, you know, headache reduction. There's a bunch of things that it's supposed to address. So Christy Fulmer is another one of our nurse practitioners. She's had training and has been doing Botox injections. So Botox is actually, it's the botulism toxin. And it's been used for years and years for a lot of different things. But one of the things that she uses it for medically is headaches. So if people are having tension headaches, you inject the Botox into the muscle belly where the nerve innervates that muscle and blocks the release of the acetylcholine, and then allows that muscle to relax. And so that is also effective in spasticity. So you know, there's individuals that, let's say you've got multiple sclerosis, you know, the spasticity that is part of that condition. You can receive Botox injections, and then you don't have to fight with the spasms. It can help you move better because you're not fighting against those spasms, and it can also make you feel better because you're not tight and having those spasms when you move. Botox is temporary. It's it wears off after about 3 to 4 months, and so then you would need continued injections for those for your first spasticity. Cosmetically, she does fillers, so if someone wants to have more full lips per se, she provides that service. That is a cash pay service. Shared care, so a little over a year and a half ago, the decision was made by medical staff and our board to discontinue delivering babies in our community. And what we did was we still decided we have Dr. Cole and Kristen Fulmer still want to help with the pregnancy and the prenatal process. And so they are working with the contemporary OBG, YN in Kearney, or the OB group in North Platte. And so if a young mom comes in and is expecting and they identify that she's pregnant, we work with those two facilities where Dr. Cole would do some visits so people can stay in town to do visits. And then, you might have, every third visit or so going to Kearney or North Platte, and you come back to Cozad for your visit. And then as it gets closer to delivery time, then you have more visits at the specialist's office. Certainly the advantage of that is that if you're delivering and you're in North Platte or Kearney, you've got the availability of the NICU bed. And so if there is a complication with the child at the time of delivery, they've got the advanced specialized care on site to take care of that. And then you don't have to send that baby out in a ambulance or a helicopter. So. Infusion services, we touched on that a little bit before. So, we've been doing blood transfusions for a long time, IV antibiotics for a long time. During the height of the pandemic, monoclonal antibodies, those infusions were very, very successful at treating the COVID infections. And currently, with the current strains of COVID, the monoclonals that they have aren't as effective at treating the new strains. I'm sure they're probably going to continue to work on that, but also they're working on oral medications, and those are out there to kind of combat that too. But certainly at the height of the pandemic, the monoclonals were extremely effective at treating COVID. We also have infusion services for patients with multiple sclerosis. So a lot of those individuals will need a monthly infusion. I'm not sure what the exact medication is, but previously people would go to Kearney to have that infusion. And so we can certainly offer that in-house. Chemotherapy is coming soon. So as part of our new pharmacy remodel, we didn't have a picture of that because it's kind of hard to see, but part of that remodel is we've got what's called a hood room. And so you go in through a specialized sealed door. You're in an area where you put on what we would call our PPE, our personal protective equipment, to keep any toxic chemicals away from you, so you're safe from that. And then there's a room that's a negative airflow room that sucks air out. So if you've got any toxic fumes when you're mixing medications, that's getting shot up and outside. The other room has positive airflow. So when you're preparing medications, it basically maintains sterility there. So you don't have any other room air coming down on those medications. You're essentially keeping your medicine clean. So we are waiting on flooring. So one thing that we struggled with throughout the pandemic was availability of supplies. HVAC units, we had to wait for the ventilation system that sat over the hood room to suck all that out. we were told originally it was like a 6 to 8 month wait time. It showed up a month earlier than we expected, so that was good. But there's a lot of stuff during the build that certainly didn't show up in a timely manner. And the flooring is one of those things that didn't. So right now we're just waiting on the flooring product to show up. It's looking like it's going to be another 8 weeks before it will. We can get the floor installed, and then we can get that hood equipment installed to do this special airflow that we need so we can prepare that. So it won't be long, we'll be offering on-site chemotherapy as well. If those chemo drugs do not need to be mixed on-site, we can offer it now. But if it's chemo drugs that need to be mixed on-site, then we have to wait to get our new system put up. Another thing, when you're looking at all of our infusion rooms, all of our new patient rooms, they all have negative airflow. So all of them are equipped to handle COVID. So if you've got a patient with any airborne disease, whether it's COVID or tuberculosis, anything like that, they can flip a switch and it sucks air through the room and up and out through the roof.
When you were talking about the monoclonal antibodies and the different strains of COVID now,
Yeah.
are they still naming the strains with the Greek alphabet? Or
I believe so, yeah.
where are we at?
I'm not sure how far we are down the line, but we're a ways down the line.
Because they're going to start using people's names.
Probably. It'll be
like the storms.
hurricanes,
Yeah.
Yeah. And then one thing that's happening in the EHR portion, our electronic medical record, is we're getting what's called My Care Corner. And so, our patient portal will have access through an app. So you could go to either Google Play or the Apple Store and download the app. So if you have a test result, it will automatically fall into your chart, and you'll get a notification of it. So if you needed to have a blood draw done, and let's say, one of the physicians inspected or suspected that you've got, an infection, they do a blood draw. As soon as those results fall into our electronic health record, it is going to pop up on your phone and tell you what that is. Okay. So that's pretty nice. It's also a double-edged sword, though, and that's one thing I want people to realize, is because you get it the exact same minute that it falls into the physician's EHR. When it falls into his computer, it doesn't pop up like it does on your phone and say, hey, Mrs. Smith's, results are here. It's in a different area that they have to it notifies them like that. They click on that, they pull up your file and it'll tell you. But the odds of them sitting at their computer waiting for your test results to come in, they're not sitting there waiting for that. They're seeing a patient in the room. So if let's say, Dr. Latova goes and he's doing a physical and he's in a room with a patient for 20 minutes and then he comes back out, you may already be calling him because it fell onto your phone. And there's a lot of lab findings that may be quote unquote out of the norm. And so it may be labeled as high or low, but it may be clinically insignificant. And so oftentimes patients will get a result and they'll be really, really concerned about it, when really there's not a whole lot to be concerned about it. But they don't know that. Their doctor does. But because you get it instantaneously at the same time it goes into their computer, so if they're not calling you right away with the result, and you're getting it on your phone and you're wondering how come I haven't got a call, it's because odds are you saw it before they did. Does that make sense?
So here's a question
Yeah.
for you. Like, you have a mammogram.
Mhm.
Will those results go into this too?
That's a perfect example, you know, so if there's an abnormal finding on a mammogram, it can, you know, it's a concern for you, right? You know, I would just, you know, when you get that result, you know, first thing, if it's a result that you feel is not good, take a deep breath, be calm, you know, and you can call that provider's nurse. They will get back to you. But again, you know, don't think that they're neglecting you because they haven't called you within 5 minutes.
Well, my question is really, because in the past, you've always gotten a letter in the mail.
Yes.
So is that going away?
No, you'll still
Just-
get that, but if you sign up for the portal,
Yeah.
you get it instantaneously.
Is that something you want patients to do, is to go that route?
That is a personal preference, you know, and I think if you were gonna ask, you know, and maybe I'm putting words in the mouth of some of my providers, but I feel fairly safe saying that if you were gonna ask them, I think, you know, different patients have different personalities. And some patient personalities are that if you saw that your, you know, potassium level was 0.1 above what the norm is, you know, you may have a ton of anxiety, you know. So if, and then it's eating you up. I would think that, you know, if I was a physician and I had a patient that I knew had a lot of anxiety about things, maybe they, you know, would benefit from having the portal or looking at it right away, because they could get really, really nervous and worked up over something that maybe isn't an issue at all. You know, that level may have been like that a good share of their life, you know. And so I think it just comes down to individual variability, but if you do have it, I think it's nice. You can see results, and a lot of times you might, you know, say you sprain your ankle and they're concerned, okay, maybe there's a fracture, we're going to go ahead and film it, you know, and then the radiology report falls back and goes into your portal and you're looking at it, and then you see, oh, you know what, radiology report says there's no fracture. Oh, good, you know. But maybe there's a hairline fracture of the fibula, and you're thinking, oh my gosh, that's terrible news. You know, I've got an ankle fracture. Well, your fibula is your non-weight bearing bone in your lower leg, and you're probably not going to need to be put in a cast and limited for 8 weeks. You know, so there's a lot of different things, and so just be aware that if you do have the portal and you are getting those results,
Take a breath.
take a breath, you know. But we're required to have that by law. You know, if we're required to give those to you instantaneously. We would like to put a 24-hour delay on it, so the physician would have time to review it, you know, look at your case, and then be able to contact you and guide you in an educated manner, so you're not jumping to conclusions that there's no need to. But the law's law.
I have blood drawn on a regular basis, like every 3 months, which you reminded me, I just had that done yesterday, and I wasn't home then in the afternoon, but a nurse called and gave me the results from the doctor that everything's fine. But then I can go online at my convenience.
Yes.
Rather than having it pop up on my phone, I go online and I can look at the numbers and compare. And I have to do that. I have it on my phone.
Yeah, you've got all those options.
Yeah.
See, I would be-
like being able to do that.
See, and I would be the anxious person that's like, no, I don't want to, just
Well,
send me the letter.
This is an ongoing thing, it's no big deal, so it's nice to just do it when it's convenient for me instead of having the phone alerting me and in the middle of something else. And like you said, sometimes you look at the numbers and uneducated person, you don't know what they mean.
Yeah.
I get the message from the nurse that everything's good, then I'll go on and look at the
Yeah.
numbers.
Yeah. Another good thing with the My Care Corner edition is that you'll get appointment confirmation and reminders by text if you choose to sign up for that option. So when you go to the clinic, they can ask you, hey, do you want me to put in your cell phone number and click the box? So, you know, the day ahead of time or 3 days ahead, whatever it's set up to do, will give you a reminder. Just like a lot of us have been getting for the dentist for years now. Our electronic medical record now has that option as well, which I think is a nice benefit. So some things that are happening behind the scenes that you don't necessarily see. You know, you see this brand new big addition, there's a lot of construction work there. But what you don't see behind the scenes is with our IT, we really upgraded our infrastructure this last year and a half. Really brought it up to snuff in terms of operability, you know, functioning servers that are working well, working on our wireless access points, all those types of things to help improve security, cybersecurity, also just improving functionality for the system for the providers. If they were bringing a computer into the room, oftentimes the signal would drop, and so it took some troubleshooting, but we were able to get all of that figured out. Also, our electronic medical record continues to have updates that are going to improve efficiencies for the caregivers in our system, and also have built-in safety processes too, to ensure patient safety as well. And we've just kind of been going through with those updates and also looking at, you know, the way we've been doing things traditionally for decades, you know, and it kind of morphs and changes as things occur. When you introduce an electronic medical record, and those things are kind of a one size fits all, you know, they're going to see our hospital the same as they see Dinkelman, is the same as they see Gordon, is the same as they see Atkinson, but everybody's a little bit different, you know. If we try to force the computer to do the things the way we did things on paper, a lot of times that's going to cause some hiccups. So we just need to try to adapt our flows to work how the system was designed, and then it'll work more efficiently for us, and we'll have less headaches. The hospital roof was a big repair. We had some struggles with that over the last several years, and so the new addition, of course, is all new, but we did the large portion over the majority of the hospital. We have 3 smaller sections left before our roof will be good for another 20 years. At least that's what the warranty says. So, and then physician recruitment, we're looking at, you know, again, I want to add a third provider to our ED and hospitalist staff to help, you know, allow our traditional providers more time to see patients at the clinic, and then they would, you know, round and see their patients over at the hospital, but they would work with that hospitalist as a liaison. So, but then also, you know, they say that it takes 2 to 4 years to find an MD or a DO. Dr. Nemeth has been with us coming up on 28 years. He's not going to work forever. And so at some point we need to be looking for his replacement. So we've started doing that. And it may be, you know, maybe it'll be 6 months we'll have somebody. If we do, great. Maybe it'll be 4 years. You know, but you can't wait until they tell you they're ready to retire. So we've got to be looking for that right fit. And then that's just a pretty picture of Meadowlark Point with the fountain. And yeah, Meadowlark Point is certainly a big asset to our community. It's filled the void. We have, you know, traditional assisted living. We have memory care. We kind of have some advanced care rooms there too, where, individuals need a little bit more help with their medications, and, maybe a little bit more guidance. So great service out there. And then this is just kind of a shot of the hospital from the new addition from kind of the southeast corner, that one on the top, and this would be from the southwest corner.
Is your long-range plan out at Meadowlark to add additional units around that pond, or?
No. I think at one point in time, when they started, 17 years ago, the original sketch showed, some independent living homes on the other side. And at the time, I think maybe that was a good idea. But right now, I just don't think we want to get in the real estate business where we're building homes and then we're worried about, getting individuals to move into those and rent those out. I think we'll let the city work on the housing shortage, which there's a housing shortage, but they certainly have worked hard to add more homes on the northeast corner of town. And so
Does the hospital own all that land?
So we do own all that land around there. Yep. Yeah. So there's some discussions about, what we can do with that land. And so we're kind of working through that. But at this point, we don't have any specific plans nailed down for it, if that makes sense.
Yeah.
So, but certainly it's a great neighborhood, And you could go over and go fishing for the lake all the time. Okay. Any other questions?
One thing they talked about having was a putting green out there. When my dad lived there, I wish they'd had that for him.
Yes. Yeah. That,
And with Lyle Davis, I'm kind of surprised he didn't get that.
surprised you didn't have that, yeah. That was drawn up kind of on this other half of the lake on the other side with the original mock-up. One thing I would like to see is, kind of a viewing platform over the lake. And so if anybody.
Like a dock?
Yes, a dock with like a covered shaded area. And, I guess I wasn't calling it, the only reason I wasn't calling it a dock is because we don't really want people jumping off of it or taking boats out there. But you look at a lot of community lakes, and although this isn't necessarily a community park, I think it would be a wonderful Eagle Scout project for someone to build, a platform that residents and their families can go out on. They have some benches on there, a covered platform that they can, stay out of the direct sunlight, and then they can, and the water is so clear there, they can, grandkids can watch the fish. We actually do feed the fish out there. And people can throw food out, and those fish are just fun to watch. And it gets to the point where, they hear you coming, they can feel the vibrations in the ground, and they just come up for it. And I know that, you walk out on that dock, they would just come right up. And I think that would be a neat thing for the residents and their families.
Is there any thought about putting lighting around the walking trail up there?
So we don't have any immediate plans for that. There was talk about that at one point in time, but we don't have any direct plans for it. If there's anyone that would want to make a significant donation to help that happen, I think we can make that happen. But certainly the struggles in healthcare in the state of Nebraska right now are pretty significant. Costs went up on average for the Nebraska hospitals 20 to 25%. And reimbursement is not going up that much. They're keeping it flat or cutting it, or you've got privatized insurance plans that are putting up more barriers to care, additional prior authorizations to be performed for procedures. And it's just, they're making sure they're not spending money, but yet, our costs continue to go up. And so there's a difference there.